Welcome to This Explainer. Today, we're taking a really deep dive into the high-stakes, incredibly fast-paced world of a massive cardiovascular clinical trial. We're not just looking at the medicine here. We are looking at the math that actually makes the medicine possible. Because ultimately, it's the biostatistics that determine if a new experimental drug becomes a life-saving standard of care or just another failed experiment. Let's get right into it.
So, what happens when a clinical trial doesn't go according to plan? Because let's be real, they rarely do. Medical research is absolutely not a straight line. It is packed with dropouts, unexpected side effects, statistical noise, you name it. Today, we're walking through a narrative case study to see exactly how biostatisticians navigate these roadblocks to find out if a drug actually works.
Section 1. The Cardiovascular Screening Dilemma.
Okay, our case study kicks off with a really serious problem, an aggressive cardiovascular condition that desperately needs a new screen and treat protocol. To prove the experimental treatment works, you've got to find the right patients, and you have to find them early. So investigators use a receiver operating characteristic curve, an ROC curve, and they intentionally decide to decrease the diagnostic cutoff score. By shifting this cutoff value lower, moving up and to the right on the curve, they maximize the test sensitivity. Why? Because the absolute main goal of this screening phase is to cast a massive net. They want to ensure that absolutely no early-stage patients are missed. But you know there's a catch, right? Here's the inevitable trade-off. You literally cannot just maximize sensitivity without paying a statistical price. When you widen the definition of a positive result just to catch every single sick person, you're inevitably going to catch healthy people too. This causes a massive surge in false positives. And because of that, the positive predictive value of the test totally plummets. Basically, if a patient gets a positive test result now, the actual probability that they truly have the disease is significantly lower. It's a calculated sacrifice. You tolerate more false alarms just to guarantee zero missed cases. Section 2. Calculating the absolute benefit. All right, let's fast forward 5 years. We've screened the patients, randomized them, and followed them meticulously. Now it's time to unblind the data and see if this experimental treatment actually holds up in the real world. And the raw 5-year disease incidence data comes in looking incredibly promising. In the placebo control group, those getting standard care without the active drug, the disease incidence was 8%. But in the experimental treatment group, the incidence dropped down to 4%. Now, the crucial part is figuring out what this difference actually means. We calculate the absolute risk reduction by just subtracting the treatment incidence from the placebo incidence. So 8% minus 4% gives us exactly 4%. This is our absolute benefit. It tells us the raw percentage point reduction in disease risk that is directly attributable to taking our new drug, completely bypassing any of those potentially deceptive relative statistics you often see. We can actually take that 4% absolute risk reduction and translate it into a much more intuitive clinical metric, the number needed to treat, or NNT. The math here is simple. It's just 1 divided by the absolute risk reduction. So 1 divided by 0.04 gives us exactly 25. This is a super powerful number. It literally means a physician needs to treat exactly 25 patients with this new drug to prevent 1 additional negative cardiovascular event. It just makes the math so much more tangible, you know? Section 3. Proving statistical significance. Okay, so we've got our absolute risk reduction of 4%. But biostatisticians are totally skeptics by nature. We have to prove this 4% benefit is a real, reproducible clinical effect and not just a fluke of random sampling noise. To do that, we look at the 95% confidence interval. In our massive trial, this interval spans from 1% to 7%. Notice anything critical there? It does not cross or even include 0. Because the entire interval is positive, it proves our treatment effect is genuinely statistically significant. Now, compare this with a smaller, underpowered pilot study done on this drug years ago. That initial study found no statistically significant difference between these exact same groups. Why? Simply because its sample size was way too small to detect the clinical benefit. That pilot study actually committed a type 2 statistical error, a false negative. It failed to reject the null hypothesis even though the drug worked perfectly fine. It failed because of the math, not the medicine, a fatal lack of adequate statistical power. Thankfully, our massive trial fixed that.
Section 4. Surviving the dropout dilemma.
All right, just when the investigators think they've got a total slam dunk, a major plot twist threatens the entire validity of the study. Watch this crisis unfold over our 5-year timeline. Year 1,
Flawless baseline randomization, perfectly balancing all those known and unknown confounders. But in year 2, patients in the experimental group start complaining of really severe medication-induced headaches. By year 3, this escalates into a massive compliance dilemma. 20% of the treatment group drops out entirely because they just can't handle the side effects. So by year 5, the investigators are staring down the barrel of massive attrition bias. Think about it. If they only analyze the patients who toughed it out, the results will be wildly skewed because these dropouts aren't random. They are directly related to the treatment itself.
So how do they save the study from this selection bias? The team absolutely must execute an intention-to-treat analysis. This is the mandatory, gold standard, conservative approach for randomized controlled trials. It means analyzing every single participant in the exact group they were originally randomized to, regardless of whether they dropped out, stopped taking the meds, or barely adhered to the protocol. It feels counterintuitive, but it's literally the only way to preserve that pristine prognostic balance we created on day 1.
But as always in biostats, there's a trade-off. While an intention-to-treat analysis is strictly necessary to prevent attrition bias and way superior to a per-protocol analysis that only looks at the perfect patients, it naturally dilutes the apparent effectiveness of the drug because you're counting patients who didn't even take the full course of medicine. It pulls the final hazard ratio closer to the null value of 1.0. So yeah, the numbers look a little less dramatic, but it gives you a much more realistic picture of how the drug will actually perform out in the messy real world.
Section 5. Flawed follow-ups and bias.
So our rigorous trial is complete, but the scientific process never really ends. A separate research team decides they want to validate our findings in a totally different clinical environment using a retrospective case control study. But as we're about to see, good intentions do not always equal good study design. Look at the structural matching of this follow-up study. They recruited 100 patients with advanced cardiovascular disease from a highly specialized tertiary cardiac hospital, and then they matched them against 100 healthy controls recruited from a local fitness center. I know, right? You can probably already spot the disastrous flaw here. By comparing hospitalized heart patients with highly active community controls, they've introduced massive selection bias. Specifically, this is known as Berkson bias. Because they drew their cases from a specialized hospital, those patients are systematically unhealthier, they have more comorbidities, and they're vastly more complex than the general population, let alone the super active folks at a fitness center. Any statistical difference they find here might just be due to this extreme baseline mismatch and have absolutely nothing to do with the drug itself.
On top of avoiding bias, investigators have to choose the exact right math for their data. Let's say they want to analyze a continuous variable, something like the mean reduction in LDL cholesterol across these populations. Because they are comparing a normally distributed continuous variable across exactly 2 independent groups, treatment versus placebo, the independent 2-sample t-test is the correct mathematical tool here. Now, if they had expanded the study to compare 3 or more independent treatment arms simultaneously, then a one-way analysis of variance, or ANOVA, would be absolutely mandatory. Using the wrong test basically invalidates your entire conclusion.
Which brings us to a final, really important thought. We've seen how shifting cutoffs changes predictive values. We've seen how dropouts force an intention-to-treat analysis to literally save a trial, and how poor control selection absolutely ruins follow-up studies. So next time you read a flashy headline about a numerical drug, how will you interpret the statistics? Are they actually giving you the absolute risk reduction, or just hiding behind big relative percentages? Was the trial properly powered, or was it just prone to bias? Keep these biostatistical principles in your back pocket, and I guarantee you'll never look at medical claims the same way again. Thanks for joining me on this explainer. See you next time.